Try that again. Go live. Here we go. Go live. Going live. Okay. Hi, Elliot. Hi, this is Elliot Fishman, and welcome to our latest, not Facebook Live, YouTube Live. And we're here at YouTube headquarters in my office, or to be exact, in Lily's office. Here we go. Let's take a look at what we're thinking about today. Well, we're going to talk about pancreatic lesions. And we're going to talk about the ability to look at cystic pancreatic lesions and be able to, but it's not moving. We're able to look, oh, there it is. All right, I'm giving Lily a hard time here because we're using her computer, but what I want to quiz you on is some cystic pancreatic lesions. Now, of course, there are multiple cystic pancreatic lesions. Pseudocysts, IPMN, very common, 3 to 5% of patients. Serous cystadenoma, less common. Variable appearance from multiple septations to thin septations to multiple cysts to unilocular cysts, but they're always benign. And they can be really large and aggressive looking. Mucinous cystic neoplasms, more common in females, typically in the 40s. Typically have septations, typically located in the body of the pancreas, typically always considered malignant and will be resected. We talk about neuroendocrine tumors. Most neuroendocrine tumors are hypervascular, but they can be cystic with a vascular rim, can be tricky, can look like other lesions, particularly if you're in late phase imaging. And in younger patients, we talk about cystic and solid tumors of the pancreas, so-called SPEN tumors or solid and pseudopapillary neoplasms, typically teenagers and people in their 20s, but also can be seen in patients who are older than that. So what I'm going to do at first is just talk about one case, and that case will be a pancreatic pseudocyst. I think one of the things to remember is pseudocysts do happen, and we can see pseudocysts, but it's important. Clinical history becomes very important. Really what you're looking at becomes really important. So here's a cystic lesion in the pancreatic head. You can go through a differential diagnosis. You could say a oligocystic serous cystadenoma. You can see an IPMN. That would not be illogical, but typically the history is good. You had a history of pancreatitis or prior history of pancreatitis, and pseudocysts, most of them will resolve over time. You don't need to do much about them typically. Sometimes they need to get drained, maybe a drainage through the stomach when they're large pseudocysts, and they're not draining on their own when patients are symptomatic. So you can think about 1 to 2 centimeter pseudocysts, or you can think about these pseudocysts which measure 10 centimeters. So this next lesion is a really nice example of that. Okay, so I'm getting pseudocysts out of the way, and I'm going to tell you that I'm not going to really show you any pseudocysts. So let's get started. We'll look at case number 1. What are we looking at in case number 1? Now, I will tell you that for some reason or other, my clicking of my slides and them appearing is really a delay. So I'm going to do the best I can. I don't know why it's such a delay. But here it is here. You can see a cystic lesion in the body of the pancreas. Well-defined water density, no septations. Okay, what am I thinking about? Well, let me give you another case. In this case, we're going to look at it and we're going to see multiple cystic lesions. They're a little bit larger. They are well defined. A pretty good look at the lesions in the body and the tail of the pancreas and the head of the pancreas. So what do you think about when you have multiple cystic lesions? Good question. Well, typically these lesions, well-defined cystic lesions, are typically IPMNs. IPMNs are very common, as I mentioned, up to 5% of the population. It's more common in older patients. It's a very important lesion because these are the ones we typically talk about following. Current recommendations for IPMNs over a centimeter is perhaps a 9-year follow-up by ACR guidelines. Only about 3% of IPMNs will become malignant, so it's a lot of work for a small percent of cases. Is often a challenge. A lot of work is being done looking at biomarkers within the fluid of these cysts and how do you treat them. Again, if a patient has a family history of pancreatic cancer, perhaps you're going to be more aggressive. But again, we talk about main duct and side branch. Everything I showed you was a side branch. Main duct meaning that the pancreatic duct is dilated over 8 millimeters. That has a higher incidence of malignancy. You can have a mixed type, which is dilated pancreatic duct and cystic lesions. That also has a higher chance of malignancy. But again, it's a very challenging process and something we're trying to use AI for. So that indeed will become very, very important to us. Now, okay, so that's like the first set of cases. Now let me show you a few other cases. What I'm going to show you is this patient, when he gets here, of a large cystic lesion in the pancreas. When you look at this case carefully, I want to know, what are you going to be thinking? Well, there's septations, there's solid and cystic components, and it's very large. And here it is on the coronal display. So when you look at it, what are you thinking about? Well, I'm thinking about some sort of cystic lesion that's cystic and solid. I don't see a dilated pancreatic duct, but the lesion is critical in that it's a very large lesion. So what could this be? Now, I will tell you, and I will show you some other examples, this is a lesion that's kind of challenging. This lesion can be purely cystic, can have thin septations, multiple septations, can have a Swiss cheese configuration, can stretch vessels, can be somewhat solid looking, as in the second case. And in this case, when you look at the vessels, you'll see that things like the hepatic artery and GDA are stretched over the patient's mass, which is something that indeed happens. And in those scenarios, you're talking about a very unusual tumor, but it's not that uncommon. Patients will often get surgery not because these are pre-malignant or malignant, but because they're large enough, and anything large enough can cause symptoms. Sometimes they're picked up incidentally, but these tumors never become malignant. They have no malignant potential. The big challenge perhaps with them is they can look like other things. They can look like MCNs perhaps. They can look like pseudocysts, but when you stare hard at this case, you realize you're looking at multiple septations, some solid components, but mainly cystic components. So then you say to yourself, what am I dealing with here? Well, you realize you're dealing with the diagnosis of serous cystadenomas. And I'll bring up one more case. Serous cystadenomas can be large, septated, have calcification centrally or peripherally, can enhance, can stretch the vessel. Very, very challenging diagnosis, but something you need to be thinking about. So serous cystadenomas is probably the second category of cystic lesions we're talking about. Now let's go forward. Now with serous cystadenomas, tail or head of pancreas are the most common locations, but truth be told, it could be found anywhere within the pancreas. If I go to this next case, and I'm going to show you 3 more cases or so. What is this case? You see a cystic lesion in the pancreas. The lesion has septations, and the wall is maybe a little bit thickened. It's in the body of the pancreas. Now, one thing important to look at in patients is what's the patient's age? Well, in this case, the patient's female, and the patient's in their 40s, and it's in the body of the pancreas. So what lesion occurs in the body of the pancreas? Yes, IPMNs can occur there, but the thickened septation would be concerning. Serous cystadenomas can occur there, but it doesn't quite have this appearance. So what exactly are we looking at? Well, that's a very specific diagnosis. So let's look at another example. So we'll look at an example, and again, you look at the cystic lesion, it has a definable wall, maybe some enhancement, and it has septations within the lesion. That becomes extremely critical. And what are we dealing with? Well, again, look at those septations. So now you're thinking cystic lesion and septations. It's not the look of a serous cystadenoma. It's not the look of an IPMN. If you have thickened septations in an IPMN, then it's considered malignant. You're looking for nodularity and septations. But this lesion can also be very large. You can see the septations here. And I'll show you a third example of this case, or this diagnosis. And you see you're dealing with a very, very large tumor. And in this tumor, you can see septations. At times, you can see nodularity. It's typically well defined. You can see some wall enhancement. And what are we dealing with? Well, these are the typical scenarios when you're dealing with the mucinous cystic neoplasm of the pancreas. Mucinous cystic neoplasms are relatively uncommon, but they do occur. They're always considered malignant and you need to resect them. They're more common in patients who are in their 40s who are female. It's almost always a 40 female. So we talk about cancers, or serous cystadenomas also are a later age. These mucinous cystic neoplasms typically occur at a younger age. And here's just a nice example showing you some of the key features that we see: smooth contour, thick enhancing wall, peripheral calcifications occasionally, and thickened septations. And the septations, to me, are the single most important thing. Now, when we look at cystic pancreatic lesions, we look for septations. We look for calcifications. We look for nodularity. We also look, is the cyst wall enhancing? It's one thing to see a definable cyst wall. It's another thing to see a cyst wall enhancing, which you can see very nicely in this case. So now I see a cystic lesion with irregular walls, and the first thing I'm thinking about is, boy, if this is an IPMN, it's malignant. If this is an MCN, it's a high-grade dysplasia. But is there anything this could be else besides those two things? Well, then you're thinking to yourself, what else gives you a cystic lesion, but that cystic lesion has rim-like enhancement? That's really the question. These lesions can be small, or they can be larger. Most of them are in the 1 to 3 centimeter range, but sometimes I've seen them bigger than that. And here's a second example of that, which is coming up in a moment, which again makes you think of the possibilities: cystic pancreatic lesions. Well, could this be a serous cystadenoma? I guess it could, but usually it's vessel stretching, not enhancement. MCNs show a thickened wall. Occasionally they can enhance, but not really brisk enhancement, so I don't particularly like that possibility. Pseudocysts just do not enhance. What else could this be? What else could we be thinking about in this case? I mentioned these lesions can be larger. You see this one's about 2 cm, peripheral enhancement, no dilated pancreatic duct with it. What else can we possibly be dealing with? And here's just a good example of a third case I mentioned where the lesion is cystic, the rim is enhancing, it's larger. There's not really the septations of an MCN, but it's that rim enhancement and thickened rim that become important. MCNs can have a thickened rim, but they have septations. And sometimes this tumor can be confused with that. And what was this? Well, this was a cystic neuroendocrine tumor. So cystic neuroendocrine tumors, most neuroendocrine tumors are hypervascular throughout. These are in the periphery, commonly develop mets to the liver. Again, they can be associated with things like MEN syndrome, M-A-N syndrome, in about a quarter of patients. So a very, very interesting diagnosis of a cystic neuroendocrine tumor. Now the last case I'm going to show you is this example. Now here you see a cystic solid lesion by the tail of the pancreas, which is coming to you any moment. So now you're going to think to yourself, how is this different than the other cases you showed me? And what's very specific about this case? Well, that's going to be a good question. When we look at it, we'll go again to coronal views. I do find coronals to be helpful looking at septations, looking at enhancement, looking at relationship of the tumor. So I really like to look at that, and I'll look at it in this case. And what I'm seeing then is not only the lesion in the tail of the pancreas and the axial, but you can see it's a septated lesion. So what am I thinking about? It's a great question. Well, this lesion, I'll tell you, can be large or it can be small, can be any part of the pancreatic gland, and it can have peripheral calcification or central calcification. So it's one of those lesions which has calcification. To be fair, IPMN can have peripheral calcifications, MCN peripheral calcifications, typically the serous cystadenomas central or peripheral calcifications. But what's this lesion? A very central calcification, and then I'll show you another example with calcifications even more central. So now you're dealing with this, it doesn't really look all that cystic, it's cystic and solid. So what gives you cystic and solid tumors? In some ways, serous cystadenomas can look like that a little bit, but what else gives you that appearance? And it's a very good mimicker because it can be very large. Now, if I told you this was an 18-year-old female, you'd say, ha, It's a SPEN tumor, because SPEN tumors are typically large tumors, and they occur in the pancreas in women in their teens and 20s. But SPEN tumors can be seen in older patients as well. They may not, as in this case, have all the cystic components you think about. Here you might think of a hypovascular neuroendocrine tumor. You might think about a funny serous cystadenoma. You could think about a MCN, kind of a tough case, but this was a wonderful example of a solid and papillary SPEN epithelial neoplasm or SPEN tumor. SPEN tumors are kind of cool. We've seen a lot of them. They're often a great mimicker. Again, patients with SPEN tumors will get them resected, 90% 5-year survival, so they do very well. It has a range of appearances, and you could see why it's kind of tricky. When it's in a 19-year-old or a 22-year-old female, it's not that tricky, but otherwise it can be very, very tricky. So I've shown you a number of lesions. I think there was one more I wanted to show you. There's a lesion that's cystic, but it arises, I would say, off the pancreas or at the edge of the pancreas. Because of that, it can simulate things like a mesenteric cyst or a duplication cyst. And what is that lesion? What could it possibly be? It's a great case because it abuts the pancreas. There's no calcification. It's a benign lesion. Patients often, when these lesions are biopsied, get terrible pancreatitis. These will be resected a lot of the time, but if you really know what it is, you may not resect it because it has no malignant potential, though it can get larger, and theoretically anything gets larger can rupture. And this is an unusual tumor. It's a lymphoepithelial cyst of the pancreas. So a very, very unusual tumor. Again, benign, periphery more common than tail, a really nice example of this tumor. And then finally, I'll just simply conclude and say, wow, I showed you a lot of cases. I showed you some key findings. There often is overlap. It's always easier in conference when I have the answers, but it's something to consider understanding cystic pancreatic lesions. You can see a lot of that on CTisus. There's a bunch of lectures on this topic, and it's a very important topic because management of the patient is critical. For many of these lesions, you want to simply follow them and do nothing. You don't want to do pancreatic surgery, which can be very time-consuming. Maybe the word is not time-consuming, but it's a long post-op course, complications, and the like. So anything you can do without surgery is going to be great, okay? Even though my friends are surgeons. So with that, I thank everybody for their attention, and I hope everybody has a great day. And I am now going to end the stream and say, what's a song with something in the stream? Water in the stream? No, that's not a song. Islands in the Stream. That was by Kenny Rogers and Dolly Parton. So with that, have a great day. That took like twice as long as the other